So here's the interesting case, and there's a novel technique that we use for this procedure. It was a patient that referred to our office for peri-implantitis of implant number 30. As you can see on the CT scan, there's an advanced vertical bone loss around that implant, and is a bit of bleeding, pus drainage. She has another implant on number 31. As you can see, this one is completely integrated, no issue. But number 30 has a bone loss more than 50% of the implant length, and it's not savable. So what's the process? So most of the time when you see the peri-implantitis as an advanced stage, you have a severe bony defect. And that bony defect, we have to go through regeneration and then come back and then place an implant. So you have like 3 stages to repair those defects. Stage 1, explantation, remove the implant, clean up and let the tissue heal. Stage 2, come back, do the regeneration, bone regeneration. So to generate the bone. And then step 3, do the implant placement. So from start to finish, these cases takes up to more than a year to get the tooth back again for the patient. But this novel technique that we describe right now, we can do everything almost in one stage. But it's a very technique sensitive. We're going to go through every stage one at a time, and we can review this case, which is very interesting in terms of the result that we also get. As you can see, this patient, it's the bone is gone. I have this also. This is, you can see it on the x-ray. It shows the vertical bone loss. And this is the way I explained to the patient with the line. See, this is the bone line. At one point, a bone was there. Now it's down there. But as you can see, this implant was a little bit, placement was shallow. I mean, I like to see those implant placed a little bit deeper, but for some reason, they used a longer implant and they couldn't push it down, probably because of the nerve. But you can use the shorter implant and go a little bit deeper to have a better mucosal seal, probably because of that you went through that. That's one of the topics that we usually talk, and then we can discuss that one later on too. So go back to the CT scan. So what we do is we're gonna go and we're gonna do the measurement here. So how much bone we need to the length, the nerve area, the location of the nerve, and also how much bone we need to generate that area. Go from there. So what's the stage 1? The stage 1 is to removing implants. So as you can see, there's like a crown there, there's a abutment there, we have to remove those. And here's a short video of the implant removal. As you can see in this video, we use a terfine burr. So this terfine burr, we use a copious irrigation, and is a special speed. We're going to go all the way through the implant. It's very, very important that you go through all the way to the last thread. We usually leave about 1 millimeter of the bone around the last thread as a safety margin. We're not going to go through that because of the nerve. As you can see, the terfine has the window on it. You see the depth. Also, every laser marked on that is about 3 millimeter. So I'm guessing this implant is about 10 millimeters. So if I go all the way to the third one, I'm almost there. So when you get to that part, it's easy to remove. Most common mistake that the clinician do is they don't remove bone properly. That's why they can't get the implant out. And then if they remove the implant, it may come out with a tons of bone, because what we're going to have is atraumatic explantation. What it means we only want to remove only implant, leave the bone there. We need this bone for implant placement. We need this bone for bone regeneration. So that's the important part of it, to be atraumatic. How? Using terfine, go all the way down, minimizing the amount of the retention, which is the bone. And then, as you can see on this video, we use the counterclockwise ratchet with the very controlled, not much force, we can remove it. If you don't remove the bone, use the ratchet. First of all, you may break your ratchet. You may break the bone, break the implant. It happens. Especially on the narrow implant, you may break it into the bone, and then good luck. It's worse than the root tip to harvest or retrieve it. When as you can see, the implant is out. Now what we're dealing with, it's a large bony defect and tons of infection. So what we do is, that's the most important part, it's decortication through the debridement. We're going to use a spoon-shaped curette, clean everything out, lots of irrigation. Also, we use laser, erbium chrome laser for decortication, open up the bone marrow, create a bleeding, disinfection, make sure everything is out. It's very, very important we out of infection there. After that, it's ready to evaluate the site for implant placement. Can we place another implant? Yes or no? It looked like yes, we can place another implant. As you can see this video, the 4.8 by 8 millimeter Straumann implant was placed. It's shorter than existing implant, as you can see, but we can sink it in. Why? Because we want to create a mucosal seal around that area. I mean, I'm guessing why this patient gets to the peri-implantitis, because it's a long implant, shallow placement, the bony seal was less, so that's why create that peri-implantitis. If we sink it in, then we have a good amount of the bone and the soft tissue and keratinized tissue around this implant, so we can preserve the bone, we can save the bone, we can protect the implant in the long term. So the implant is in, and now we need a bone grafting. But as you can see, because of the peri-implantitis, it's a huge bony defect on that area. So what we need to do is we need to create a block of the bone or some sort of the wall to repair that wall. So in this case, instead of using the block graft from like a Corey's technique, we use a titanium mesh. This is a very thin mesh, it's a medical grade mesh. We cut it, fit it in size, and we use 3 tiny screws, micro screws, to secure that titanium mesh on the buccal area. As you can see, we use the latchet and a driver to secure it on that area. It's secured by the 3 micro screws, and now everything is ready for bone grafting. You can see this. We use the autogen chip maker ACM from Neobiotech. This chip maker, it comes with a different depth and the size. We go to the retromolar area, just to the distal of implant number 31, and then we sink it in, and then we harvest the autogenous bone. This is autogenous bone will coming in. As you can see, it's the most important part of that procedure. Why? Because this autogenous bone carries the biological factor, growth factors for bone regeneration. So we use those to regenerate bone. So if we don't use those, or if we use the allograft, it will compromise the result. We can add it some allograft. Maybe I love to have 70% autogenous, 30% allograft, but not 70% allograft, 30% autogenous, because that will compromise the result. So we'll do that, and then we fill it out, and then that's going to be a primary closure of the area. So, all right, this is the intraoral photo of the area. You see the video, and sorry, the image is a little bit blurry, but you see there's a titanium mesh here. This is the area on the back. We harvest the autogenous bone, and then as you can see, we fill everything all the way to the top. We fill it up to the top. The beauty of this titanium mesh is it can contain the granule. If you don't have that, everything gonna be washed away. It wasn't stay there. So that's why it's the most important part of it, to contain the whole area as a part of the wall of the bony defect been creating. And the next photo is about the closure of the area. As you can see, primary closure. As we discussed, the soft tissue management is one of the most important part of this procedure. Any premature exposure, any tissue dehiscences, it will compromise the result. You see there is a hole in the tissue, the bone graft will come out, and then you ending up with the recession, with the implant exposure. It's going to be a total mess. That's why the primary closure tension free is very, very important for those cases that we achieve that. And this is the follow-up photo. As you can see, everything is healing very nicely. As you can see on this x-ray, see in the photo, see the titanium mesh. It's there, it's not exposing it, it's safe. And the next step is going to be a final step, is the second stage of the implant, uncovering. It's a very short procedure, it takes about like a 5-10 minutes, numb the area, get exposed, put a healing cap there, and we send that case back to the general dentist for implant restoration. As you know, in the most cases of the peri-implantitis, due to severe bony defect, it takes months and months for bone regeneration to fix those. But this case, with the technique that we use, we did everything in one stage. In less than 4 months, we can finish the case and send it to the general dentist. So here, and then this is the final x-ray. As you can see, it's a wide healing abutment, 6.5 by 4 millimeter was placed here. And if I put it back to back, then you can see with the previous one, first of all, as you can see, it's a shorter implant, 4.8 by 8. This is about 10 millimeter implant, but just look at the placement. We are well below the bone, about 2 or 3 millimeter below the bone, and we have enough room for the emergence profile for that new crown. And the most important part is a mucosal seal. We have a very good connective tissue and mucosal seal for that new restoration that will protect the implant from future bone loss, compared to the old one that you can see there was a shallow placement, there was no seal around it, and that's why it went through that vertical bone loss and peri-implantitis and implant infection. Thank you so much for your attention, and then I'll wait for the comments on that area.